Ladies and gentlemen, we're here at the European Society of Cardiology Congress in London, where we've just completed the Garfield AF annual symposium.
So the question is, understanding the real world, does it actually improve clinical practice in comparison with trials? And so what we need is both trials and registries.
The Garfield registry is a unique, ongoing international registry of patients newly diagnosed with atrial fibrillation.
It's my pleasure to present the data which just have been analysed by the Thrombosis Research Institute from London about the differences between the German cohort being recruited in Garfield and the international cohort. 62% of these patients are being treated with NOACs in comparison to 38% of the international population.
In Japan, NOACs usage is much higher and aspirin rate is lower for newly diagnosed NVF patients. This is the big difference in Japan. The aspirin use is very low, and after the NOAC improvement, the use of NOACs percentage is rapidly increased in Japan.
The rate of stroke and mortality is slightly higher than in the global population, but you have seen that it can be attributed, of course, to the age and to the fact that they had a previous stroke in a large number. In France, we see that, firstly, the proportion of patients absolutely not anticoagulated is rather low as compared to the other countries.
The rate of death is at least three times the one of stroke systemic embolism and 4 times the one of major bleed.
That death burden is a persistent risk, of course with an important and ongoing risk for both stroke, systemic embolism and major bleeding in a cohort where 60% of patients initiate anticoagulant therapy at baseline.
In terms of antithrombotic therapy, the UK essentially mirrors what's been going on in the rest of the world, in that there's been a slight increase in overall antithrombotic use.
In the future, whatever the quality of anticoagulation, it might well be that the cause of death will not be so much influenced because most of the causes are not amenable to anticoagulant therapy.
The decrease of all-cause mortality may come from the longer longevity of Japan.
I think that the most important message to give to my French colleague is to continue to include in the last cohort of Garfield.
I think the single most important message from the Garfield registry so far for the German population was that we were successful in reducing the number of patients being treated with aspirin.
Anticoagulation decreases massively the risk of death by a huge magnitude and the risk of stroke systemic embolism as well. These are the main facts that we have to remember from a 2-year outcome in Garfield.
Everything from Garfield data so far, we learn a lot. We have improved our service and care for patients with AF in China.
Garfield not only matches but exceeds the quality control and the registry standards of many trials and most registries.